So immunotherapy has really, in the last 5 years, I would say, transformed the treatment of oncology. It went from something that I was being accused of by Dr. Badros as sort of wasting my time in the lab and studying to what has really become the mainstay of treatment for a lot of different diseases. And fortunately, I have to say, even myeloma. I mean, I started working on immunotherapy and myeloma in 1999, and there were many times that I asked myself, is this just the wrong disease? I mean, I never really doubted that immunotherapy had a value. I wasn't sure whether myeloma was the right setting, or for that matter, what kind of immunotherapy would ultimately work. But I think we've made a lot of progress, and I don't think immunotherapy is going to replace chemotherapy or transplant or anything else, but what is going to happen is that it's going to increasingly become integrated into various aspects of the treatment of the disease. And what I've highlighted here are 3 areas that we are currently working on that I think are actually ideal for immunotherapy. Specifically smoldering myeloma, minimal residual disease, which you've heard a lot about today, and also high-risk / relapse refractory myeloma. So I already showed this to you earlier. Let me just, and I can tell you that there is a lot of evidence. So first of all, let me back up by saying that what happens when a patient gets cancer is that their immune system becomes ineffective. It becomes ineffective not only towards their cancer, but it becomes ineffective in general. And I'll give you an example of that. When I was a medical student, I injected myself with Candida, which is the yeast that is in bread and everywhere else. And I got a rash that went from my wrist to my elbow, and it itched like crazy. And this is a sign of an intact cell-mediated immune system. The T cells are capable of attacking that Candida and generating this huge rash. We use this, we have used this in several clinical trials to determine the overall global immune responsiveness of patients. And if we get a 1 centimeter in duration, we're happy in myeloma patients. So we go from, I mean, granted I was 23 years old or whatever, but a whole arm rash to 1 centimeter in duration, and we're excited about that 1 centimeter in duration. That, I think, really objectifies how profoundly immunosuppressed cancer is. And so there are a lot of theories that I think are backed up with clinical data to suggest that there is this concept of immune surveillance, that our body is constantly developing cancers at a 1, 5, 10 cell level, but we have an effective immune system that can fight it and prevent it from growing out. The best example of that is in the patients that are clinically immunosuppressed. Patients with AIDS and patients that have undergone a solid organ transplant, lung, kidney, liver, whatever, pancreas, that are on chronic immunosuppression, their likelihood of developing malignancies is higher than in the general population. So why am I telling you that? Because I think myeloma, in addition to being the disease that we treat, is actually also a very interesting disease to study because it offers significant opportunities. I think you're all aware and certainly have heard this morning that it's a disease that starts off with MGUS, which is a pre-malignant condition, to smoldering, and we've talked about that there's 3 phases of smoldering to active to relapse myeloma. There is evidence to show that in the smoldering disease setting, our immune system is much less compromised than it is as you move forward. And the biggest example of that is data that was actually generated by Madhav Dodapkar, who used to be at Yale. I think he went to Emory now. And this is basically looking at the response of the patients with smoldering myeloma to a protein, which in this case is called SOX2. So this is a protein that's found in stem cells. And what this data shows is he measured the T cell response to this SOX2 protein and was able to show that in patients that had an effective anti-SOX2 T cell response, that's the top line, they did not progress over the 3 years that they studied these patients. And in contrast, patients that did not have this SOX2 specific response progressed. So what this data is saying, and in the same paper, he also showed that SOX2 specific responses were very prevalent in MGUS, were still detectable in smoldering, but again, in smoldering is when they started to drop off, and once you got to actual myeloma, completely inexistent. So this is an example where the immune system is very effective in terms of preventing disease progression, which is why I think therapeutically smoldering myeloma is a very interesting setting in which to come in potentially therapeutically to try to elicit these responses and keep them going even longer. There have been trials, and I'm not going to be talking about them, of using Revlimid with or without DEX in smoldering myeloma, and this has shown that it has made an impact. And I think not so much the DEX side of it, but certainly the Revlimid side of it is probably because to a not small part, it's actually eliciting and generating a more effective anti-tumor immune response. The next thing that I want to talk about is checkpoints. So basically, when you think about how a T cell works, and the T cell is a cell on the right, and the myeloma cell is a cell on the left, it's not just a T cell and a myeloma cell, but there's this incredible network of proteins that interact, as I've depicted here. And as I've depicted, the red ones are the brakes, and the green ones are the go signals or the accelerator. So basically, there have now been, and this has been the area that has mostly revolutionized the field of immunotherapy, there have been antibodies that have been generated against this protein called CTLA-4 that is FDA approved. This is the biggest one that I'll be talking to you about a little bit, called PD-1, but you can see that there are a variety of other ones. There are also proteins that activate CD40 ligand, 4-1BB, and OX40. So this field is becoming increasingly more complicated, but now therapeutically targetable. And it's the CTLA-4 and the PD-1 antibodies that have really generated sort of the new era of active immunotherapy that went forward first in melanoma and lung cancer, and in the liquid tumors, Hodgkin's lymphoma was the first one, and there's data in myeloma. So actually, Dr. Badros here was very instrumental in some of the trials of pembrolizumab with pomalidomide, which I'm not going to be talking about. But this is the early data that came out of pembrolizumab with lenalidomide. And the interesting thing in myeloma is that the antibody itself shows zero activity, and it's only when combining it either with Revlimid, lenalidomide, or pomalidomide, which is the work that Ashraf did, that did we begin to see evidence of activity. And this is called a waterfall plot. And what this shows is basically the deeper this line, the deeper the response. So these patients right here are all patients that achieved a complete response. In contrast, these are patients that had disease progression. And what you can see is that more than half of these patients actually got a response. The thing that was even more impressive is that there was a significant response in this trial to patients that were previously lenalidomide refractory. So again, you know, once a drug stops working, the odds of you continuing to stay in that drug and get a benefit from it is very, very small. But really what this tells me is that the benefit is not so much in the direct anti-myeloma activity of Revlimid, but in the immunomodulatory activity of the Revlimid alone. And the duration of response of these patients was rather significant, again, even in a population that was Revlimid refractory. So this is all really good news. Ashraf had a nice trial that subsequently was turned into a phase 3 randomized multi-center international trial, and then a whole bunch of badness happened last summer. So what happened last summer is that the FDA came out with this statement right here, that pembrolizumab in combination with IMiDs, either Revlimid or pomalidomide, increases the risk of death in patients with multiple myeloma. And you can read the actual thing that was out here, and it was based on these two trials. So this is one trial where, again, in the blue were the patients that were on pembrolizumab. I'm pretty sure that's right. And that eventually their risk of death was higher. No, I'm sorry, I think it might have been in the red. And clearly here in the newly diagnosed, it was the same story. Now, I will say that this unfortunately took a drug that was basically the wonder child of immunotherapy and discarded it to hell. And I will argue, and maybe we can have this conversation when all three of us are up, that I think the enthusiasm was overly enthusiastic. There was this, like Greenspan said, this, irrational exuberance, thank you. So we went from irrational exuberance to irrational negligence. And I think we really need to tease out this data to try to understand what's going on. So every single anti-PD-1 trial was shut down within a matter of a few weeks in July, and slowly now the FDA is opening them back up again. but opening them back up in the multiply relapse setting, not in the upfront setting. So a newly diagnosed trial would not be possible right now because of the environment that we're living in. I will also say that probably one of the reasons why this is that this came out is not necessarily because the drugs themselves are actually killing more patients with myeloma, but because many of the centers that were involved in the therapies were not aware of the complications and toxicities that these drugs can actually cause and were delayed in the treatment of them. Now, this is an opinion, but I think a lot of these studies were done in places where there were 3, 4, 5 patients, and it wasn't clear that they were actually either myeloma centers or immunotherapy centers. And I want to make that point because certainly from my experience with my patients, there's this general belief that immunotherapy is benign, it's natural and it's benign. It's not natural and it's not benign. People die from immunotherapy, and I think the biggest example of that is allogeneic transplantation that we talked about earlier. That is immunotherapy as good as you get, and yet there's a significant mortality associated with that. So I wanted to spend a little bit of time on this because there is a lot of literature out there on this, and I just want to say that I don't think these drugs are dead, but I think they're being slowly revised and restudied in the way that they should be. So the next thing I want to talk about is T-cell therapy. So this, so the PD-1 is our antibodies that block T-cell engagement with their target, which in this case is myeloma. But then there's the T-cell therapy itself. Basically, the analogies that I use is, again, the cancer corrupts the immune system. And the analogy that I give to my patients is it would be as if you were to see a battlefield with a whole bunch of soldiers that are armed, but they're drunk. They're asleep, they can't do anything. And so what you would be doing, I guess, with the PD-1 would be putting the machine guns in their hands. What you're doing with T-cell therapy is waking up all these soldiers that are already armed and getting them to function better. And an approach that we have pioneered in my lab and subsequently at Hopkins has been using marrow infiltrating lymphocytes. So the concept is we go into the bone marrow of patients that have myeloma, and those T cells are intrinsically myeloma specific, but again, because they're drunk, they're not effective. And what we've been able to show is that when you look at that, for example, if you compare the blood and looking at the yellow bar, there is very little activity to the myeloma there. If we take the bone marrow out directly, there's very little activity, but if we activate these cells, their anti-myeloma activity goes way up. And when we give these cells to mice that don't have an immune system and we give them a human myeloma, what we can see is that with the activated blood cells, there's just a minimal delay in tumor outgrowth, but eventually all these mice die. And in contrast, with the mills, we were able to actually cure these mice out to 10 months or so. So we have subsequently gone on to do some clinical trials, and the first one, we were able to show that there was a direct increase in the tumor specificity, the ability of the myeloma to recognize the tumor itself, that ranged from a very high amount to a very low amount, but nevertheless it increased in everybody, but the extent of that increase correlated with the clinical outcomes. So patients with the highest amount of tumor-specific MILs were the patients that had the highest likelihood of achieving a complete remission, and in contrast, patients with the lower tumor-specific T cells had a very low likelihood of achieving complete remission, and in fact were higher to have had progressive disease from that. Furthermore, looking at the response of the T cells in the patients after the transplant, and this is looking at 6 months is when it was more predictive. The patients with the highest amount of anti-myeloma activity were the patients that were in a complete remission, and you can see that this persisted over time in contrast to everybody else. Now, this was done in the context of a transplant, and the overall clinical efficacy from something like this could not necessarily be determined. But we currently have an ongoing trial that is only targeting high-risk patients, and the reason for targeting high risk is, one, because I think it's a need that is unmet, and two, because of the nature of the disease, we'll hopefully be able to get an answer in a slightly shorter period of time. But the idea is that basically everybody gets their mills harvested, and then they're randomized in a 2-to-1 manner to either get transplanted with mills or without mills, and then everybody starts on lenalidomide or Revlimid until disease progression. So we have completed enrollment on this trial, and I was just talking to some patients that are on it during the break, and we're going to be doing our first analysis this summer. So this is when half of the patients will have been at least 2 years out to see whether we can see some evidence of efficacy. But for the patients that are in this arm that did not get mills with transplant, what we're going to be doing is opening up another trial, and this will hopefully be opening in the next few months, where they are going to be randomized to either getting MILs with anti-PD-1 or MILs with anti-PD-1 plus lenalidomide, plus Revlimid. This trial was ready to go in July and was shut down by the FDA because of what I told you about, that any trial involving Revlimid or pomalidomide and an anti-PD-1 was no longer going to be allowed. The problem that I think is a little bit unfortunate for us having designed this is that our idea was initially to have this be their first relapse, their first line of relapse after the transplant, but because of the toxicity signal, the FDA has basically mandated that patients have to have gone through all standard therapies, so they have to have received both IMiDs, Revlimid and pomalidomide, carfilzomib as well as Velcade, and potentially even daratumumab before they can go on to this trial. And the other thing that they mandated is that they wanted a randomized trial. So the randomization here is basically whether they're going to get Revlimid or not get Revlimid. And so the idea here, which is very different from the way these drugs have been used up until now, is the way anti-PD-1 is used is that you're putting it into a patient in whom their immune system is already not functional. What we're doing here is we are activating the immune system ex vivo in a bag. So now we're going to combine these activated T cells with this antibody to try to prevent the T cells from becoming dysfunctional and maintain their functionality. So we're not trying to wake them up, we're trying to keep them awake for a very long period of time. So that's what we're doing, and I can tell you that so far what we're seeing with a lot of these MILS therapies is very minimal toxicity. Also, the clinical data that we have is not what I call a wow data, which is very different from what people are showing now with CAR T cells. So CAR stands for chimeric antigen receptor. So basically what it is a construct that has on the outside an antibody that recognizes a surface protein on, in this case, the myeloma cell, and on the inside of that same construct, it has the machinery to activate the T cells. So it's chimeric in the sense that it recognizes, it's a B cell, it's an antibody on the outside, and it's got this T cell infrastructure on the inside. And this has been the second thing that has revolutionized the field of immunotherapy. So the first were checkpoint inhibitors, the anti-PD-1, and the second are CAR T cells. And in fact, this summer, it was sort of a landmark decision. The FDA approved for the first time 2 CAR T cell products. One that targets a protein called CD19 for pediatric acute leukemia. And the second one is also, again, CD19 for diffuse large cell lymphoma, which is a high-grade lymphoma for patients. So it's the same construct in 2 different diseases. Myeloma has BCMA. BCMA stands for B-cell maturation antigen. It's a very interesting protein because it's expressed very late in the maturation of plasma cells from B cells. And so it's relatively unique to plasma cells themselves. And as you can see from this data, there's quite a significant response rate. So 100% of these patients responded. Now, there were 18 patients, 100% response rate, of which 27% of them were in a complete remission. And you can see that those remissions appear to deepen over time because over the course of the next 5 months, that response rate went from 27% to 56%. Now, what is happening is that we are clearly seeing with CAR T cell therapy that we can take patients with bulky disease and get this disease down. This is a wow effect. There are these pictures of patients that have a bone marrow that's 80–90% plasma cells, and at 30 days or 60 days, basically there's no detectable tumor there. So it's very effective and it's very rapid, and as you can see, it's got a very high response rate. The caveats to this are a few. One of them is the cost. The cost for the commercially available products right now, which again are for pediatric ALL and for adult diffuse large cell lymphoma, vary between $300,000 and $700,000 for the product, and probably another $200,000 to $300,000 to treat the patient, because many of these patients are ending up either in the ICU or requiring very intensive treatment. There is a push now, and they are beginning to see patients that have slightly less toxicities that are being treated as an outpatient, but we haven't gotten there yet. And the other aspect of that is this thing called a cytokine release syndrome, which basically is requiring patients to go into the ICU. But the other thing that people aren't talking about are the lack of durable responses for patients that don't achieve a complete remission. Ashraf and I were talking actually this morning before this whole thing started. So the first BCMA trial that was done was actually done at the NIH, and I think there were 18 or 20 patients or something like 12, okay, even better, of which 3 of them were complete remissions. And those 3 were sort of the heroes of the paper. One of them is his patient, and one of them is my patient, and 2 out of these 3 have already relapsed. And my patient relapsed within 13 months, and I don't know how long, 12 months. So the durability of response, even in patients that had achieved a complete remission for the BCMA CAR T cells, is unclear. And the second thing that is unclear is how and when these relapses are associated with something called antigen escape variants. So this is a complicated concept, but I want to try to explain it to you because I think it's important. The idea is, think about me as being a myeloma cell, and a CAR is only targeting my hand. But that's sufficient to kill me if my hand is eaten. And so that's what happens, is that you have a whole bunch of myeloma cells that are dying because their hands are being eaten, but you have that one cell that for whatever reason, despite the fact that their hand is eaten, that patient can, or that cell can still survive. And so now you start seeing cells surviving that are handless because that CAR killed the hand, but that myeloma cell can still circumvent the likelihood of living without a hand and surviving. That's called antigen escape. That the target that was originally there is gone, but the cells have still survived. And the reason for that is because the only thing that a CAR T cell is targeting is that one protein. In the case of myeloma, BCMA, in the case of leukemia and lymphoma, CD19. And this is data from lymphoma, and this is data that was published in the New England Journal in December that received a lot of press, even lay press. I think it was actually in the New York Times as well. The thing that's impressive about this data is that these are patients that were multiply relapsed, like most of these CAR T cell patients are, in which the average progression-free survival is expected to be in the order of 8 to 10 months. And what you see here is that the patients that achieved a complete remission, which by the way is roughly 50% of them, at 2 years, less than 50% of those patients have relapsed. So these patients that achieved a complete response, half of the patients that were treated, have had a durable remission that at least is out 2 months. But what I would like to bring to your attention is where that red arrow is. So those are the patients that didn't achieve a complete response, that achieved a partial response. And their time to progression is 1.9 months. So I don't think society can afford to give a $500,000 to $800,000 therapy where only half of the patients are getting a durable remission. And that's the story with regard to CARs in diffuse large cell lymphoma. I think with regard to CARs in myeloma, the verdict is still out because nobody that I'm aware of has still seen the durable overall survival data because it's too new of a therapy. An approach that we're taking with MILs is this whole idea of trying to minimize the likelihood of developing antigen escape variants. Remember I told you it's not just the hand, but in order to kill, you have to attack my heart and my stomach and my liver and a whole bunch of other things. So what I'm showing you here is data that we've generated in the lab where we took either PBLs or MILs and made CARs to CD38, which is basically the daratumumab target. And we're looking to see how effectively these CARs can kill myeloma cells. So you can see here, 3 days after the co-culture, 5% in the of the PBL CARs are still present, and there's complete killing of the tumor cells that were treated with the MILs. And then what we did is we added more tumor on days 3, and now this killing, 36% of these cells are still surviving, and only 1% of these cells are surviving. And we added more tumor, and now these PBL CARs are only killing about 40%. And here we're still getting about 90–95% killing. So we believe that this is another approach because of the fact that MILs actually target multiple antigens, that combining it as used with a CAR may be one benefit. Shifting gears, how do we treat the minimal residual disease? There's a lot of talk about MRD negativity and the importance of achieving MRD negativity, and I think what this is going to require for long-term cures is an immune response. So we made a vaccine that we call it GVAX because it produces this protein called GM-CSF. So what we have is a cell line that I actually made many years ago and combined it with 2 myeloma cell lines that we bought, and that's the vaccine formulation. And we did our initial trial where we targeted patients that were immunofixation positive. So their M spike was 0, but their immunofixation was still positive, and they had to stay that way for 6 months. And the idea was that those patients, if they got vaccinated, they hopefully would become immunofixation negative, and that would translate into a delay in overall survival. So what we did is we enrolled a lot of patients initially to observe them and had them come back 6 months later. And in the observation arm, these are the patients that were initially put on the list but did not get vaccinated. And the reason they didn't get vaccinated is highlighted here. That half of them achieved a complete remission, so just going back, half of the patients within that 6 months were actually down here, but the other half relapsed. And these patients had to be on a Revlimid-containing regimen, but it could be Revdex, it could be VRD, it could be whatever, as long as R was in it, and continued on whatever they were on. The patients that got vaccinated dropped everything except Revlimid. So if you take the hypothesis that the vaccine isn't doing anything, the observation group was actually on more therapy than the vaccination group. And the first thing that we saw is that we were able to generate a very effective immune response, shown here, that this is myeloma-specific immunity that we could see as early as 3 months out. But interestingly, in the patients that ultimately progressed from the vaccine, that response completely disappeared at 1 year, whereas it persisted in the patients that got an ongoing clinical response. And these are the survival curves, that the patients that were vaccinated that are now out past 5 years, we have not reached the median progression-free survival in these patients, in contrast to the observation group where their median progression-free survival was 10 months. So we had a very profound benefit from this trial, although not randomized, but we will hopefully be opening within the next month, although I've been saying this for the last 2 years, this randomized trial, which is going to be randomized, of GVAX versus placebo, and this is what the patients got the first time, just 1, 2, 3, 6 months, but now we're going to continue that out for a total of 36 months. And so I feel that even in this era where we are now up to virtually 100% complete remission rates with a very high, 100% response rate with a very high complete remission rate, we still don't know what to do with patients that achieve a complete remission, and this offers an opportunity to do that. So what do I think here is that immunotherapy is here to stay. It's an adjunct to a lot of therapy. I think certainly in the field of active myeloma, one could potentially argue that in the smoldering field, this could really be an initial introduction into the treatment of the disease in terms of preventing that transition to active myeloma. CAR T cells are clearly things that have revolutionized the treatment. They have shown dramatic efficacy, but the durability and the cost are things that need to be factored in as we move forward. And I think we need to not turn off the story to PD-1, because that is something that, in my opinion, needs to be further developed and tested. So that's it, and thank you.